So we welcome to the Emergency Management Conference, Mr. David Forbes.
Thank you very much for that kind of warm introduction, and I'm going to share my slides here. Okay. And so just checking, I don't know, just checking that you can see that and hear me okay. I'm assuming that that's the case unless I hear or see something to the contrary. Is that correct?
Everything's great. It's in edit mode though, so if you want to click it on to presentation,
I do.
That will work wonderfully.
Perfect. Thank you very much. And I'm still adjusting to this. No matter how many times I do it, I still learn more about this, the technology each time. So look, thank you very much for the warm introduction. Thank you very much for inviting me to speak today. I'll be talking about barriers to mental health. And look, there are many things that we can talk about in relation to barriers to mental health, but I will be talking about it today in the context, given the time we've got, in the context of stigma and kind of barriers to help seeking in relation to mental health in the emergency service context. So it's taking that lens. I'm not for 1 minute saying that there aren't, a myriad of things to be thinking about in terms of barriers to good mental health generally, but that's the lens I'm taking today. Just a little bit about Phoenix Australia and who and what we are. Thank you for the introduction. It kind of gave a little bit of a background to me. But Phoenix Australia, it's an independent not-for-profit. It's affiliated with the Department of Psychiatry at Melbourne University. And, the central part of this slide is really our mission, which is improving outcomes for folks impacted by trauma. But with a very specific kind of focus on kind of optimising wellbeing and functioning for those who put themselves on the line for the sake of their community and their country. So defence, national security officers and emergency service personnel. We're a national centre of excellence in trauma. So as mentioned, we developed the Australian guidelines for treatment of PTSD. We have a very strong research focus in terms of moving the dial forwards in terms of interventions from as far upstream as we can go around prevention through to how do we improve interventions for those who have severe and chronic problems. As well as then focusing significantly on translation. What does this mean for organisations in relation to their policies, in relation to their practices, and in terms of their skills as well. We also have a really strong lean in on the international side, as mentioning I'm the Vice Chair of the International PTSD Guidelines, but also kind of deeply connected with the group, with the Five Eyes group, who most would be aware of, and kind of co-chairing a group there that is focusing on, that brings together the centres of excellence in veteran and military mental health across the Five Eyes countries. But we are discussing the potential to expand the parameters of that from military mental health across to military and first responder mental health. And then linking in, and I co-chair that with my Canadian colleagues. So look, it's a great privilege to be able to speak to you today. And as you can see from this slide, the work that you do, the work the Emergency Services Foundation does, is kind of core to the raison d'etre of my job and Phoenix Australia's existence. In relation to what we know about mental health in high-risk organisations in Australia, we're not starting from a blank slate. One is what we know from all of our own personal experience, both directly from a lived experience perspective, as well as what we hear from each other, what the health professionals learn from the community, from the emergency service community. But we also know a bit on the basis of a pretty solid emerging body of evidence that's building up. So there's the mental health and wellbeing program that was done through Defence, the Mental Health and Prevalence and Pathways to Care study, predominantly led through the University of Adelaide, that told us a lot about the prevalence of mental health and wellbeing issues in current serving and ex-serving veterans. There's the AHW report that tells us a lot about the issue about suicide and suicidality amongst current and ex-serving veterans. And of course, as all of you are aware, there's the really important work done by Beyond Blue in the University of Western Australia with the Answering the Call study that looked at the prevalence of mental health and wellbeing issues across the emergency services sector. But of course, in relation to this, when we're thinking about this sector, there are some unique features about this sector. So it's not really just about the numbers in terms of rates of mental health difficulties or problems. We need to understand and have at the forefront of our mind, what's core to this sector. And what's core to this sector is that it's a professional, dedicated workforce. People choosing this line of work because it's meaningful, it's rewarding, it's important to them. It's challenging and demanding, that's true, but it's meaningful and rewarding at the same time. So understanding that these are workforces that are professional and dedicated. We do know from the reports that I've just talked about that we do see higher rates of mental health conditions that escalate further post-transition. We know that from across those three bodies of research. We also know that what's core to kind of the breadth of the emergency services workers is, facing what's a foreseeable and predictable risk of repeated exposure to trauma. For many, not all, in the context, but those trauma exposures occur in the context of broader operational stresses, broader organizational stresses, environmental stresses. So for example, if it is an operation in a particular site, there's climate conditions in the area of operation, particularly if we're talking about offshore deployments of all kinds across the different agencies, and of course, personal life stresses. So whilst we see that, foreseeable predictable risk of exposure to trauma is common, it really needs to be seen in the context of the interplay of these other stresses that go with these lines of work also. It's not just all about the trauma, although it's a very important part. So what do we also know about the utilisation of services for those who might have mental health problems or accruing mental health problems, developing in the early stages of developing mental health problems? Consistent within the community, we know that there's an underutilisation of mental health services. In the community, we see that, low rates of people who have existing mental health problems seeking out mental health services. And similarly, within the emergency service sector and in the defence sector, there's an underutilisation of mental health services across high-risk organisations. When we think then about issues about stigma and barriers, and as I mentioned, this is going to be a focus of where I'm going to be placing my focus in this discussion, albeit it is only one of a range of things we could be talking about. It's important when we think about stigma and barriers to mental health and mental health care seeking, we understand that it's quite a heterogeneous construct. It's made up of different facets. So one is what we call anticipated public stigma, which is, the way in which I think I'll be viewed by others if they think I have a mental health problem, or if they identify that I'm seeking mental health care, if that becomes known. There's self-stigma, which is the things I think about myself in relation to having a mental health problem or seeking help for a mental health problem. And then there's service concerns, which are different to both of the above 2 points, which is, if I do seek out services, will they get me? Will they understand me? Will they understand the context in which I'm working? Can I trust them? Can I trust also that they're going to deliver me good quality care? Can I get there? Is it accessible for me? And what's the expense like? Is it something that's affordable? So when we ask the question of what stops you from seeking help to emergency services or to military folks, this is what comes up as the most common responses. And and as you can see, they kind of look very familiar across these two. So from the Beyond Blue Answering the Call study, asking emergency services across the sectors, what stops you from seeking help? I want to deal with these problems on my own. I'm worried about losing the ability to work in an operational role. I'm worried about the impact on my career, and I'm worried about others seeing me as weak. In the study we did, so the University of Adelaide led, as I mentioned, the prevalence study across current serving members. We at Phoenix and I led the pathways to care components of that. What did we find there? When we asked people what stops you from seeking help? I want to manage this myself. It's important to be self-reliant, to be managing this myself. I'm concerned about what the impact's going to be, about my employability and my deployability if I put my hand up or if I seek help. How will I be treated by my leadership? How are they going to view me? Are they going to interact differently with me? And what are my peers going to think of me? So as you can see that, the body of evidence now across the emergency sector, across the military, are coming up with pretty similar stories, pretty similar patterns of thinking in relation to what stops people from seeking help if they're starting to have emerging mental health difficulties or issues. From the Beyond Blue Answering the Call study, when we look more closely at what's going on in people's patterns of thinking, interestingly, people generally were concerned more about what others would think. And in fact, they themselves felt quite supportive of other colleagues who might have mental health problems or might develop mental health problems. They themselves were quite supportive and didn't hold negative attitudes towards others, but were concerned about, as I say, the potential for others to hold views about them. And then what obviously would happen in the context of being able to be identified as such. But interestingly, individuals themselves didn't feel those attitudes towards others. So as from what I understand in terms of who's attending this, who's participating in this, both as speakers and as attendees, many of you will be versed in a lot of the mental health awareness campaigns that have occurred on a state-by-state basis across the emergency service sectors, nationally across the national security sector and defence, and of course internationally across all of these sectors as well. And there's been an enormous investment really into saying, well, can we shift these attitudes and beliefs to increase help seeking? And it's often based on the kind of messages. These are important messages, but these are the kind of messages that have been part of that seeking help's not going to impact on your career or how others regard you, that mental health champions, using mental health champions who can share their stories of the lived experience of mental health difficulties and can be able to share that with their peers, with their colleagues and with the constituencies more broadly. Promoting and making clear the agency's commitment to supporting people with mental health issues, and also education and promotion about the existence of the mental health services that exist for them. And a lot of money and a lot of time has gone into these campaigns with these messages, and certainly has moved the dial forward. There's no question that today we're dealing with a different environment than we were 10 years ago, 15 years ago. But international evaluation and research suggests that it's not having as big an impact as we thought it would. That despite significant investments in these points, in promulgating these points, in making these services available, it's not shifting the dial as far as we'd like it to. So we need to really unpack this further to better understand, what are the core elements that are interfering here, and can we do a better job? And here I want to pay credit over the course of the next 3 or 4 slides to both a colleague and a PhD student, Dr. Helen Benassi. So Helen is Director of Research at Defence. She got a Defence Sir Roland Wilson Scholarship. And from that, she did her PhD in drilling down further in the pathways to care data in current serving defence members and ex-serving defence members that I mentioned before. And so she drills down to say, can we start to pinpoint more clearly what the biggest barriers are to help seeking? So these next slides are derived from Helen's information. I have her permission to talk about these today, but I think they're highly pertinent. So in the defence data, what we had is about 20% with a likely mental health condition across PTSD, depression, and anxiety, consistent with that we see in emergency services sector, and the kinds of usual candidates in relation to those mental health problems that we see: PTSD, anxiety, levels of suicidality, levels of alcohol dependence, and depression. And what we found there is, again, consistent, about 54% of those who actually not had difficulties with mental health, but actually met probable caseness criteria, which is probable diagnostic levels of problems. Only half of them had seen a mental health professional in the last 12 months. And that rate differed a little bit by condition, but that was pretty consistent. So what do we know about those who have said they don't use services? 30% of them said they're afraid to seek care for many of the reasons we've spoken about. 82% said they just genuinely preferred to manage their problem on their own, independent of all of the other factors. They preferred to manage the problem on their own. So Helen, and together with myself and her other co-supervisors, Phil Batterham, kind of drilled down further to better understand, within these attitudes, can we start to pinpoint things more specifically? And so when we started to have a look at the items themselves, there was the anticipated public stigma, which is what I was talking about earlier, which is that people will treat me differently, they'll have less confidence in me, they'll see me as weak, it'll harm my career, it'll stop my deployment. And those items all hung together. There was the self-stigma, which is this other factor. I'd feel worse about myself if I can't solve my own problems. I'd feel embarrassed, I'd feel inadequate. I feel like I might lose control of my emotions, relating to beliefs about oneself. And the third was those service concerns in terms of the quality and the nature and the accessibility of the services. And these hung together quite separately from each other and quite incoherently within these. So these are genuinely different phenomena. So then our question is, from which one of these do we get our biggest bang for buck in terms of what's driving and not driving help seeking? So she did what we call a kind of regression analysis, which then starts to say, okay, to what degree do these predict help seeking? There was predisposing factors. Not surprisingly, women were more likely to seek help. Single people were more likely to seek help. More importantly, kind of getting down to, as you can see, as we move out to the far right of this slide, these are the things driving help seeking. So the left of the slide, these are the things that are stopping help seeking. So as we can see, as we move out to need, when someone's need and the severity of their condition has become overriding, they're seeking help. So that we're seeing that as a really strong predictor. PTSD, work impairment is pushing people towards seeking help. Interestingly, social impairment, family impairment, less so. But really important is those beliefs that we're talking about before. If we're trying to shift beliefs, what are we focusing on? That the biggest predictor we had of all of those beliefs about what was stopping people from seeking help was the self-stigma. I feel like I'm weak if I do it. I feel like I should be able to solve my own problems. I should be self-reliant. That those beliefs were in fact the strongest driver of all of the belief-related components in relation to stopping people from seeking care. As you can see, anticipated public stigma was less of an issue. Yes, it's there, but it wasn't stopping people in the same way. So we see self-stigma and resilience. I should be resilient. These beliefs as being really stopping people from seeking care. Support, important factor, but perhaps less so than some of these predisposing beliefs, as we can see. So this is really telling us, we've spent a lot of time on those early dot points that I mentioned earlier. A big investment has gone in, but we really need to be honing in on issues and relating to this belief about self-stigma, and I need to be able to manage this somehow. And there's a range of ways we can think about how we might address that. So what does this mean? I'm conscious of time, and I'm just going to do a quick time check on myself. That need, as we saw, needs a key driver of seeking mental health services, especially perceived needs. So when you feel like, okay, look, I've tried everything, I'm really suffering, those around me are suffering, and there's nothing else I can do, that's driving mental health. That overrides everything else, and the person seeks care. And the other issue in relation to that is kind of focus and then on building self-awareness and empowerment earlier, so that mental health services exist and be able to help people to manage their own mental health. How can we empower people to be able to do that? Related is that anticipated stigma, as we've found alone, isn't enough to explain the underutilisation. It's important, a lot of effort's gone into it, and we've shifted it, but there's more than one type of stigma, and the internalised stigma, the self-stigma, is one of the strongest predictors we have. How I think about myself, what I believe about myself, what I believe about the degree to which I should be able to solve my own problems and not get care from a professional service elsewhere. So that's a big factor, and it's really, really coming out to us out of the research that's been done. The other bit is that social context also has an impact. It has an impact on how people see themselves. This drives us to be thinking about how we can bolster community supports. And we think about the interactions between how members see themselves and the way they want others to see them. And also has a big implication for positioning supports to align with these preferences. So we can try and shift these ideas. And as I say, a lot of effort gone in. We can now start to target more about what attitudes we're trying to shift. But we can also say, whilst we are trying to do that, it's really important that we design services that are also at least going to work with those beliefs while they are there. Can we build up self-awareness and opportunity for self-guided and self-directed interventions so that those folks who do want to manage it on their own, we can make that as easy for them as possible. So part of what this leads on to is to work, and hopefully the Emergency Services Foundation doesn't mind me plugging the work that they're doing. But the Emergency Services Foundation is kind of engaging in a project. They're engaging with us at the moment. We're doing a similar thing with Defence, which is really to develop to better understand the stigma in help seeking for good mental health, and doing it really from a bottom-up approach. Can we develop an evidence base around a deeper understanding of the barriers and the enablers of help seeking that's going to then drive strategies and drive implementation around workplace programs and services. Kind of utilising the data we've got to bottom up, flesh that out about what does that mean. Focusing on identifying what supports or interventions in speaking to members would be of most interest to them who are experiencing, and at this point, subclinical mental health issues. Before things start to get overriding and overwhelming, and we know that overwhelms everything else, and that drives care seeking because it's got to the stage it can't be contained. When things are in their early phases, what are some of the things going through people's mind about what they want, how they want it? So this project that Emergency Services Foundation is driving is engaging up to 4 member agencies participating directly, and other member agencies also contributing by proposing tools and services and ideas, and exploring subclinical presentations and associated supports with a particular focus on workers who are in transition to retirement, experienced workers within the 6 to 10 year mark, that mid-career cohort, corporate staff who are involved, and conducting obviously everything would be completely voluntary, everything would be completely de-identified. Qualitative interviews and focus groups to try and get ground up information about what's and people can talk about themselves or they'll talk about others. We're not asking to distinguish. We don't want that information about you, or if you're talking about someone else. What's the earliest signs of changes that you noticed? What's the earliest thing you noticed in you and your colleagues? And also, what kind of support at that point do you think would have been the best thing for you? Delivered by what kinds of modalities? And through what kind of messaging would they have found helpful at that stage? What kind of mediums, messaging, how would that be expressed? And really trying to get that strong qualitative data from folks about what would have been useful for them at that very early stage to be able to build system around those attitudes while we systematically also try and shift those attitudes. So look, I know that I just spoke about one small part of the picture, and when we're talking about good mental health, it's a much broader construct than that. But I thought that was a place to start in terms of what do we know? What do we know from the existing work? How do we think about it? And where's the ESF going? What are some things that we're going in our thinking around it? So with that, I thank you for the opportunity to have spoken today.
Good on you, David. Thank you very much. Very interesting presentation. And if I can just indulge on you for a couple of questions from our delegates. The first one is from Jessica from CFA, and she just wants to raise with you what you think are the merits around doing psychometric profiling on volunteers coming into the emergency management sector.
Look, that's a really good question, and I'm assuming, Jessica, that, and I know that you can't answer me, so I know that that's tricky, but I'm assuming in asking that question, there's 2 ways we can ask that question. One is the issue of selection. The other is the issue about how do we help people best. Is that, so if I can answer it both ways?
And just before you go on, to give you a bit more context, so she was also talking around allowing people, or for us to understand whether people are suited and able to cope with the trauma that's involved with the work.
Yeah, look, it's a terrific question, and as you can imagine, it's the golden question amongst those who work in kind of high risk spaces where they're exposed to trauma in the line of their work. The reality is we're pretty good at knowing what factors predict when we look at the population levels. We might say that histories of pre-existing histories of anxiety or depression in the past, lots of trauma exposure in the past, difficulties coping with day-to-day stresses, you know, they might be rule outs. For example, we might say, okay, at a population level, these are things to say, well, look, you know, this work is really going to press you. That's at a population level. The reality is also folks who have been exposed to some of those difficulties, have mastered them, then go on to have incredibly strong and healthy careers in these workforces as well. So whilst we know risk factors on a population level, we're really not in a position to be saying you should or you shouldn't do this based on some of those risk factors. What we do say is important is saying, look, you need to understand that this is, let's give you a pretty clear view of what this job involves. These are the things that are involved in this job, and including the really difficult side of this job. And often people, you know, and giving a clear view around at recruitment point to say, look, these are the issues. Sometimes people can self-select, but we wouldn't be confident to say, if you have X, Y, Z in your background, that means you're going to have difficulties down the track. It might increase the potential for it, but by far and away, we know lots of folks who go on to have really successful careers. The other part of the question is, if we're doing assessments or profiling to some degree at recruitment, what that might tell us is about what scaffolding, if we don't know enough to say you should or shouldn't do this, what scaffolding does it mean we put in place? Learning more about saying, okay, you know, these people have had this kind of experience. We shouldn't be saying they're not doing this work. But what we do know is this is the kind of supports and flags we want to put in for them along the way. This is the kind of eye we might want to keep out. We'll give them strategies up front about how they might manage it. And this is the strategies we give the organisation to support it. So there's the scaffolding approach rather than the selection approach, if you like.
David, thank you. There's another question from Jeff from the CFA, and he just mentions that you didn't talk about age at all in your presentation, and he wants to know whether that is considered an issue or a non-issue in this.
And that's a really interesting question as well. It kind of operates at two ends in some respects. That with age and experience comes resilience in the work. And so in many respects, we see older age as a protective factor because there's maturity, there's the diversity of skills and experience, coping styles, adaptability that come with the role. Whereby age, what we find is that those who might be newer to the role might be overwhelmed early, might not have the skills and flexibility to be able to manage some of the stresses. So we find there's a risk group around the younger group where they haven't yet got that breadth of experience and maturity to manage. But it also acts at the other end, which is sometimes age is also a proxy for significant accumulated trauma over time. And where age is related to significant accumulated trauma over time, we also know that there is, you know, that has an impact. That no matter how battle hardened you are, we know that these things add up over time. And so, you know, from that perspective, you know, we're cautious about that.
Well, David, thank you very much for your presentation today. There's lots of questions coming through. Where can people, because some people would like to get in contact with you to have a chat, what's the best way for them to do that?
I'll say, so my email address is fine, and that's just dforbes@unimelb.edu.au or through the Phoenix Australia website.